Hello, and welcome to our webinar today on cross-linguistic exploration of LSVT LOUD for Parkinson's disease. And the question we are going to explore is a universal speech treatment approach, plausible. And so we're thrilled to have you all join us here today for what I think is going to be a lively and fun discussion. We have no right or wrong answer. Rather, our goal today is just to explore this important and often overlooked question. I'm Cynthia Fox. I'll be one of your presenters, but predominantly serving as the moderator today. And I'm joined by Dr. Erika Levy. She's an associate professor of communication sciences and disorders and director of the speech production and perception lab at Teachers College, Columbia University, New York. And Gemma Moyle-Gale, and she's an assistant professor in the Department of Communication Sciences and Disorders at Long Island University in Brooklyn, New York. And we'll learn just a little bit more about Drs. Levy and Moyle-Gale in just a moment. And myself, I'm the CEO and co-founder of LSVT Global. I also serve as an LSVT faculty and have been part of the research team for 25 years now. These are our bios. I won't go through those. Those are more important for you to have for future reference, in particular if you are applying for self-reported CEUs. We always like to acknowledge that we have been supported by many years from the National Institutes of Health, in particular the National Institute on Deafness and Communication Disorders, this work being led by the principal investigator, Dr. Lorraine Ramming. As well as a number of other institutes and foundations over the year that have really allowed us to build the solid framework of evidence-based practice and evidence-based treatment for LSVT LOUD. A few disclosures. I have both financial and non-financial relationships with LSVT Global. Non-financial includes a preference for LSVT LOUD as a treatment technique. Financial relationship is that I am an employee of, I receive lecture honorarium, and have ownership interest in LSVT Global. Drs. Levy and Moyle-Gale receive lecture honorarium from LSVT Global. I want to just put out a quick thank you to many colleagues of ours from around the world who have listed here, who were very kind to share some of the audio and video clips from different languages that you will be hearing, in addition to the clips from Dr. Levy and Moyle-Gale as we go throughout the presentation. So to all of you, a heartfelt thank you for joining us and sharing some of your patient samples. Our plan is to really dig into this discussion of this cross-linguistic exploration. I'm going to first go through just a few key logistics such as the CEUs. Also, all participants, your microphones are muted. That's to keep the quality of the webinar as best it can. And you should have received an email with the handout. If not, you should see in your control panel that there is a handout and you could download that at any time, or you could request it after the presentation and we'd be happy to send it to you. We'll spend the heart of this hour presenting the content of the webinar. We'll have time at the end for questions, and there'll be a very short survey that launches when you log out of the webinar. If you have 2 minutes to complete that, we appreciate it. It helps us improve the quality of these presentations. For those of you who are professionals and you'd like to use this as a continuing education activity, you are able to use this for self-report. So this is not an ASHA or state registered event for speech, physical, and occupational therapy professionals, but it can be used for self-reported CEU credit. So what you need to do, again, if you're a speech, physical, occupational therapist, or other health professional and would like to self-report this activity, email us at webinars@lsvtglobal.com to request a certificate at the end of the webinar. And we'll include that for you, including your name, date, and duration of the webinar. Licensing requirements vary by state, and attendance at the full hour is required to earn the certificate. Questions, again, can be asked, and we invite them at any time during the presentation. You can just type in a question. So if it comes in your head and you want to type it before you get it, that's great. I will see that. At the end of the presentation, we'll also have time for questions, and I'll review this process again to be sure that you are ready to ask your questions. Our learning objectives for today are to really describe the speech disorder in people with Parkinson's disease and open up the idea of what elements may be universal across languages and explore what may be language-specific deficits. We'll explain the 3 key concepts of LSVT LOUD. I'll very briefly summarize LSVT outcomes in our English-speaking work, but then really hand it over to describe these outcomes across languages and countries where it's been applied. And we'll conclude with the discussion of the perceptions of LSVT LOUD clinical implementation outside of the US in Germany, France, and Japan. All clients shown in this video or audio presentation have given their consent for this to be used for educational purposes. We please ask that you refrain from any copying of the videos or viewing outside of this course. So now let's begin with a question. Who are you? And so I'm going to launch a poll, and it will come up on your screen shortly, and you will be able to type in your answer to the question, who is joining us today? I think you can now see on your screen, are you a speech therapist, physical, occupational therapist, other healthcare professional, person or family member with Parkinson's disease, or perhaps a category we've not come up with yet? So we'll just give you a little bit of time to type in your responses. And it looks like almost everyone has voted. And let's see here, I will close the poll. I will share the results. It looks like the results sharing is not happening, but I will tell you who's with us today. We have 92% of our participants are speech therapists. Another 8% who fall into another category. So welcome. Oh, there we go. Just a little slow behind to get the poll to show. So again, welcome everybody, and it helps us to know who we're speaking to today, and we're happy to have you here. So let's go back and get to these slides. And great, now that we know who you are out there, it's time to learn a little bit more about our expert panelists here, Dr. Levy and Dr. Moyle-Gale. So Dr. Levy, I'll start with you. Why don't you tell us a little bit about who you are and specifically your interest in this topic of cross-linguistic research?
Absolutely. Welcome everybody, bienvenue, willkommen. My name is Erika Levy, and I'm an associate professor of communication sciences and disorders at Teachers College, Columbia University. I grew up in Vienna, Austria, and in Prague, Czech Republic, speaking 4 languages. Now I speak 3. The Czech is pretty much gone, but I speak French, German, and English. And my research background is in cross-language speech perception, looking at how our first language affects our second language, and speech learning, and what remains from our first language, and so on. But I'm also a speech language pathologist, and I really enjoy working with neurological populations. And one of my doctoral students was Gemma, Dr. Gemma Moyle-Gale. And while she was in my doctoral, or one of my seminars, she came up with the idea, we discussed together the fact that there's very little research on anything to do with Parkinson's disease in languages other than English. And that began her work on Spanish speakers with Parkinson's disease. Also, I was very influenced by Dr. Lori Ramig, who has a connection to Columbia University as well, and she's the principal investigator of this wonderful research on Lee Silverman voice treatment. So that really is my background. I'm very interested in putting together my cross-language interests. We don't just have English speakers with Parkinson's disease, and looking at what different languages tell us about Parkinson's disease and also about how we can treat across languages.
Excellent. Thank you so much. And again, thank you for joining us and sharing your interest and your knowledge today. Dr. Moyle-Gale, can you tell us a little bit more about yourself?
Sure. So, bienvenidos. Welcome, everybody. I'm very excited to be here today. I'm assistant professor of communication disorders in Long Island University, LIU in Brooklyn, and I'm also a bilingual SLP, Spanish, English. I grew up in Barcelona, Spain, where two languages are spoken, Spanish and Catalan. I am a passionate language learner myself as well, so I learned English and French at school. I also learned German and Dutch, some Mandarin later on, and now I've been learning Arabic for 2 years. It's a language I'm passionate about. My background is in second language acquisition and applied linguistics, specifically in second language speech perception and production. But when I moved to the US to do my master's and my PhD, and under the mentorship of Dr. Erika Levy, I really developed this great interest in Parkinson's disease. So my dissertation focused on how to improve conversational intelligibility, which is really the way we talk in our everyday lives, in Spanish-speaking individuals with PD. And just recently, a few months ago, I also started a speech Parkinson's clinic in LIU in Brooklyn, where we also have Spanish, Japanese, Korean, and Cantonese speakers.
Wow, impressive, both of you. And clearly you guys are qualified and experts for our topic today. So again, we're thrilled to have you with us. So to kick off the heart of the matter, Dr. Levy, I will turn it over to you to begin our discussion.
Great, thank you, Cynthia, and thank you for having us. So our main question, or our first question, I should say, is the speech disorder in Parkinson's disease universal? So let's think about this, and let's talk just generally about what the speech characteristics are in people with Parkinson's disease. And we know that the large majority, 89% of individuals with Parkinson's disease, have voice and speech disorders. These are characterized by reduced vocal loudness, monoloudness, often loudness decay. They can have a hoarse, harsh, or breathy voice quality, sometimes all together. They can have monotone voice, imprecise articulation, and all of this combined can lead to poor intelligibility, poor difficulty being understood. So we can go on to the next slide. Thank you. And those are, clinical characteristics, but they have a real impact on people. And, my interest is often intelligibility, getting the message across, but we need to think about the impact socially and in every other way that the speech disorder has on people with Parkinson's disease. And even people who are clinically asymptomatic or just have the beginning deficits that come along with Parkinson's disease can feel embarrassed about their speech, can have social stigma and social isolation. And it can lead to social withdrawal and lack of participation in life. And I think we're all feeling some of this during the coronavirus crisis, that we are removed. And, even by internet, it's hard for people with Parkinson's disease to communicate sometimes. And it's not in our nature, in human nature, to be so isolated. And it is harmful. So it matters a lot. The consequences, just if we think on that level, we can't be as social as we want to be if we are unable to converse or if we are self-conscious about our conversation. It can lead to it being excluded, a loss of dignity, feelings of misery. So I think the quote here is, if I have no voice, I have no life. And I think that's a really important way to think about people with Parkinson's disease and the importance of their voice. And there's that kind of more subtle level where people are less likely to participate, but it can also be more severe where people are unable to say, I'm hungry, or I need to go to the bathroom, or have their basic needs met. So this is a crucial problem. And then, it could sound theoretical why, asking about whether speech disorders and Parkinson's disease is universal. I mean, it is theoretically very interesting, and Dr. Moyle-Gale and I have long conversations about this, but it's also very practical because it has implications. So if people with PD have the same characteristics across languages, that is, if it is universal, then it would make sense that treatment for this disorder should be the same. So goals should be approximately the same across languages. If, however, people have different characteristics across the languages, then we have to treat people differently when they speak different languages. And it could be a combination of the above. So maybe there's a general way people with Parkinson's disease speak, but it's affected differently in different languages. So let's think, I think the more general way people think about it, and the reason there probably the reason there's not that much research on this, is that it might seem like a moot point, that really bodies are the same wherever we are, therefore the speech disorder in Parkinson's disease is universal. We know that motor abilities, it doesn't matter if you are in Taiwan or the United States, motor abilities are basically the same. We know the speech characteristics that I just described, they occur in every language. So, so this is the argument saying, no, there's one, there's a basic set of characteristics that people with Parkinson's disease have, and therefore treatment should be aimed toward those characteristics regardless of the language. But then there's the argument against that, and that is that the speech disorder in Parkinson's disease may be universal. However, a better way to think about it is that people come from a vast diversity of human languages. So there's sort of a contrast. There's an interplay between the universality of the neurophysiological impairment and the specific phonologies of languages. There's a vast diversity in the languages people speak. So Rush in the Czech Republic looked at speech characteristics across European languages and found that they differed. And this is not surprising. Syllable repetition rates, imprecision of consonants within the continent will differ across languages. However, what Parkinson's disease does to those characteristics is basically the same. So the speech characteristics of Parkinson's disease are similar across languages. After Dr. Moyle-Gale, there was a doctoral student, Sichao Xu, who then did work on Mandarin speakers with Parkinson's disease, and she has a whole line of research on that as well. And in her studies, speakers with Parkinson's disease who are Mandarin speakers speak slowly. So we don't know if that's because of her particular sample or because there's something about Mandarin that makes speech more slow in people with Parkinson's disease. But I think there is something to this idea of an interplay between the universality of Parkinson's disease and what it does to bodies and the specific phonologies. So for example, if we think about Mandarin tone, the word ma can mean many different things. So it can mean horse, it can mean mother, it can mean hemp or scold, depending on whether it's a rising tone, falling tone, rising, falling, and so on. And if we think about Cantonese, there are 6 tones. So wouldn't it be the case then, we know that intonation is very affected in Parkinson's disease, that there isn't as much rise and fall, and this is something that LSVT works on, but in Parkinson's disease, in hypokinetic dysarthria, there is less rise and fall pitch variation, as it's called. So this would matter in a language that differentiates horse from mother, for example, by tone, right? That would be the theory. And it might matter less in a language like English that doesn't really differentiate things. I mean, it might differentiate record from record in terms of stress, but it's not the same lexical distinction simply based on tone or intonation. Then another thing Dr. Moyle-Gale and I speak a lot about is vowel space. So Spanish has a very small vowel space. English has a large vowel space. And what I mean by that is the tongue goes much higher and the mouth is much more open for certain vowels in English. So for E, the tongue is high front. For A, the tongue and the jaw are low. And the further apart the articulators are in the production of vowels, the more intelligible you are. So Anne Bradlow has done work on people without Parkinson's disease, healthy, neurologically healthy individuals, and people who have their vowels further apart, their E further from their A, for example, are more intelligible. And we know that Parkinson's disease reduces that vowel space. It compresses it, meaning people don't move their tongues as much with the hypokinesis, kinesia. So wouldn't it be the case that this would matter more in English, where we have to tell vowels, let's say the word ship from sheep, whereas in Spanish, there is no such distinction of close vowels. Similarly, some languages have longer words than others. So Spanish would have longer words than English, for example. And then if we think about German, for example, often sentences, at least written sentences, are long, and the verb is at the very end of the sentence. So if you fade out if the loudness decays, which can happen in Parkinson's disease, then is it more affected? Do you become less intelligible if you're a German speaker than an English speaker, because the sentence might be longer in German and the verb comes at the end, so you're not sure what's happening till the end? These are all questions. As Cynthia said, these are just things to think about because there's not so much research on it. Gemma will tell you more, Dr. Moyle-Gale will tell you more about research in terms of the treatment. So then there are languages like Jalapa in Mexico. Oh, let's just go back. Thank you. And there is creaky voice in Jalapa, as well as breathy voice. So if you say the word ha, for example, if you say it typically, normally it means tree. If you say it with a breathy voice, it means he wears. And if you say it with a creaky voice, it means he carries. Now we know that people with Parkinson's disease might have a voice that's characterized as creaky or certainly breathy. So is that going to change meaning in that language in Jalapa, whereas it won't in English, for example, where we don't have those three different ways of using our voice to mean different things, to make it phonemic? Also, languages that have more consonants might be more difficult to produce. So Czech, for example, has very difficult consonants. Slavic languages generally have a lot of consonants, but there's, like in Czech, you can say skrk, 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 which means stick your finger in your throat, which is something that they used to say when I was there when people were choking. So even the sound r is really hard to make. So does that mean that people with Parkinson's disease will have more difficulty with languages with more consonants or more difficult consonants? So why don't we listen to some people with Parkinson's disease? So these are across some languages. And I think Cynthia is getting it ready to play them.
Dona Sônia, então a senhora às vezes acha que a voz está mais rouca, às vezes mais fraquinha.
Me para um pigarro na garganta que eu quero limpar, né? Eu fico... E é difícil. Às vezes eu faço assim, eu consigo que limpa ali e tudo bem, mas tem vezes que não, ela continua assim, mais rouca.
Když člověk poprvé vsadí do země sazeničku, chodí se na ní dívat 3krát denně. Tak co, povyrostla už nebo ne? I tají dech, naklání se nad ní, přitlačí trochu půdu u jejich kořínků, načechrávají lístky a vůbec ji obtěžuje různým konáním, které považuje za užitečnou péči. Když se sazenička přesto ujme a roste jako z vody, to člověk žasne nad tímto divem přírody.
So in normalen Situationen oder vielleicht in Situationen, wo ich mich nicht so sicher fühle, da spreche ich schon leiser, würde ich auch sagen. Und vielleicht auch die Artikulation ist manchmal nicht mehr so klar.
La impresión que da es que el niño va a coger unas galletas y la banqueta se resbala y cae.
Y fue muy bonito
estamos con ellos allí, nos negó y todo.
Au début, oui, parce qu'elle me pose, elle me demande des questions. Et puis, bon, elle me dit, vous feriez bien d'aller voir votre psychiatre. Alors, bon, psychiatre, j'en ai pas, bien sûr. J'en connais, mais j'en ai pas. Et je suis donc allé voir un psychiatre qui lui demandait si vraiment je sombrais vers sombrais.
Το άλλο που ανανεώνει και ενισχύει τις προσπάθειες είναι η εισαγωγή στην έρευνα τα τελευταία χρόνια σύγχρονων επιστημονικών μεθόδων που επιτρέπουν μια πιο διαζητική προσπέραση στα πολύπλοκα ζητήματα της αιτιολογίας, της διάγνωσης, της αξιολόγησης και της αντιμετώπισης.
Thank you so much for this compilation. This was really wonderful to hear the different characteristics of Parkinson's disease across languages. And I would say just from listening to that, there definitely are a lot of similarities. Certainly there's a lot of reduced articulation, reduced or articulatory imprecision, but there was also quite a lot of diversity. And so I think it's important to look at the different languages and see how the Parkinson's disease affects speech and intelligibility and participation in the different languages. And there are different hypotheses on how the language effects would go. So I've been pretty much saying that the impact would be worse if a certain characteristic is important in the language. So if we're talking about Mandarin tone, for example, I was suggesting that if tone matters, then intonational changes should really affect intelligibility and maybe social participation because you're not being understood, because you are affecting the way the word is being understood. So in other words, if tone matters, I won't understand if you're saying mother versus horse if you're Mandarin speaker, but I will in English if you're saying that. But then there's a counter argument, which is salience preserves, or there's a robustness. And that would be that Mandarin speakers make sure that their tone, their upward, downward, rising, lower, lowering, and then all the different tones are actually preserved. Or let's say when we're talking about vowel space, an English speaker makes sure that their vowels are as far apart as they possibly can, because this matters in the language. So of those two, first of all, there's very little evidence across languages of any of this. There's very little research on this, but of the two, it seems as if the salience hypothesis is winning at the moment, at least for Parkinson's disease. Maybe a little different for other disorders, but if we look at Whitehill's work, where she looked at mostly Mandarin, but other languages as well, it seems as if tone is preserved. People who have Parkinson's disease and are Mandarin speakers still keep their tone accurate, and we can tell the difference between mother and horse. So that's the research right now, and we hope to get more. And then the question is, what about bilinguals? Should people be trying to expand vowel space in both languages? If I'm trying to expand my vowel space in English, is it also happening in my Spanish? Should we be focusing on something different across languages? And let's also not forget about dialects. So for example, when we're thinking about English, there are various dialects of English, and in Spanish influenced English or in African American English, there is double negative often. And also in Spanish and in French, there are double negatives, which adds redundancy. So for example, je n'ai pas, that would be a double negative. So if you don't understand half of what I'm saying, you could still figure out what I'm saying because there's redundancy with double negatives. If in standard American English or Northeast American, however you want to call it, English, you don't have that redundancy. It's not clear that something is negative because you only say it once. So it's beyond phonology. It can be grammar also that's influencing intelligibility in a particular language. So what do we need to do? This is all theoretical right now. And again, maybe there's a little suggestion that, yes, people are universally affected by Parkinson's disease, and maybe there are some language specific influences, but there still seems to be robustness in preserving the important distinctions of a language. So what do we need to do? We need to test and treat speakers with Parkinson's disease in various languages. Listen to them just as we have now and see what's familiar, see what's consistent across the languages, and find out what is language specific and then what's language more independent, what's more language independent. With language independent characteristics, we can treat people similarly across languages, and hopefully if we know something specific that we can do to help certain features of languages or people who speak those languages, maybe we can help modify people's speech with that information. So I think that's all I have to say about this. Now, Cynthia will tell us generally about how to treat speech in people with Parkinson's disease, and then Dr. Moyle-Gale will talk about findings across languages.
Thank you, Dr. Levy. Fascinating. So I will be quite brief. I know some of you are already LSVT LOUD certified, so this is a review for you. Some of you may be new to this topic or don't know much about LSVT LOUD. So I'd like to just give a very brief overview on how we treat speech disorders in people with Parkinson's disease. So LSVT LOUD has been around for over 30 years, again, under the leadership in the research arena from Dr. Lorraine Ramig. And it's important because it's had a long history of not just looking at does the treatment work, but does it work? How does it work compared to other treatments that are matched? And those are the randomized controlled trials. And then what are the elements that change from a perceptual, acoustic, physiological, neurological level, always with the goal of understanding the speech disorder in people with Parkinson's disease, as well as trying to figure out how can we treat it better. So this is a timeline of the research. Some key concepts about LSVT LOUD. What are the key concepts? One is that the target is amplitude. Our focus is on vocal loudness. One of the key perceptual characteristics, as we learned, was soft, sometimes breathy, hoarse voice. So we're going to use loudness to override that. We deliver the treatment in an intensive, high-effort manner, and this concept of calibration is addressing challenges that prevent this nice voice we can get in the treatment room for walking out the door. So LSVT LOUD incorporates principles of neuroplasticity and really is administered in a manner to challenge the impaired system. I'm going to skip that video because we're going to see pre-post videos in other languages, and I'd prefer that we see those. But in general, what we see in terms of our target is there's this overall loss of motor energy, so movements are underscaled. That impacts all patients around the world in that they may not take a big enough breath, may not close their vocal folds all the way, may not open their mouth all the way, and out comes softer, less intelligible speech. So we think about using this cue of loud, which really is to drive a physiological output, which is amplitude that overrides the bradykinesia, slow movement, hypokinesia, small movement, and results in better, louder speech. Key is we're not teaching people to talk too loud. It's always healthy vocal loudness. So what we're going to look at now is a video of a woman speaking Portuguese. You'll hear her counting in her typical voice, and then the therapist asks her to count loud, and you'll be able to hear the difference.
De 1 até 10 na voz normal que a senhora fala. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Agora a senhora respira e vai contar bem alto, como se a senhora quisesse contar para alguém que está em outro quarto. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. De 1 até...
Okay, so I think you could appreciate the the cue of loud did exactly as that graph showed. She got louder, more clear speech, but it wasn't perfect. So it takes more than just telling people talk loud. They have to relearn a way to do that becomes natural and habitual. And that requires intensity. So treatment is delivered 4 consecutive days a week for 4 weeks, 1-hour individual sessions, daily homework, daily carryover, all with the goal of creating this lifelong habit of continuous practice, and that we have intensity not only across the dosage, but also within the treatment sessions. Third key concept is this calibration. Patients around the world, I've not gone to a country or language yet that when we increase loudness, which is required for the listener to perceive as normal, people will say, I feel like I'm shouting, I can't talk that loud. So there is a neurophysiological mismatch between a person's perception of normal loudness and how others perceive that. And then when we stimulate normal loudness, it's often perceived by the person as too loud. So this concept of calibration goes hand in hand with the motor exercises in that we're retraining people's perception of what normal loudness sounds like. Again, this has been researched over the years. I'll just highlight, again, we have 3 randomized controlled trials. I won't focus on these for this presentation. We have entire webinars on that, other than to say it is the only speech treatment for Parkinson's disease with this level of evidence, not only establishing efficacy, but again, numerous studies, over 30, examining distributed effects to facial expression, intonation, speech motor stability, neuroimaging, and the heart of what we want to talk about now, research from other labs around the world in other languages. So now I'd like to turn it over to Dr. Moyle-Gale, and she will walk us through the next segment of this presentation.
Thank you, Cynthia. So the aim of this section is to provide an overview of what has been done in other languages regarding the implementation of LSVT LOUD. And as you can see, we have diverse languages from Spanish, Japanese, French to Farsi, German, Italian, or Brazilian Portuguese, among others. Literature has focused either on acoustics or intelligibility findings or both post-LSVT. So let's take a look. Before starting to explore the Spanish study, which is the one that I'm going to focus on first, I wanted to introduce some interesting factors about this linguistic community in the US. So for example, Hispanic or Latino represent the largest minority group in the country, and actually Hispanics have the highest incidence of Parkinson's disease. However, until just recently, there was really no treatment research on this linguistic population, which was pretty surprising. So the question for us as clinicians was, so what should we do now? Should we focus on English norms? Can this be considered evidence-based practice? What should we do? And that's when the Spanish study came to be. So this is the first study that examines changes to conversational intelligibility, which really reflects how people speak on a daily basis. It's way more naturalistic, let's call it like that. It has more ecological validity. We wanted to focus on intelligibility because being understood is essential to us as human beings. It's essential to communication, and we know that many people with Parkinson's experience social withdrawal and frustration when their communication skills break down. So intelligibility, however, is a complex construct and has been investigated in different ways in the literature, as you'll see in a minute. This Spanish study examined listener orthographic transcriptions of dysarthric speech, which is the gold standard of intelligibility measurement. And as I said, the question until now was, can we use a well-established research approach in English like LSVT with this population? Our aim was to provide evidence-based practice to this linguistic community, and we stem from what we knew from English studies. We know that people with Parkinson's may be well understood on a one-on-one conversation in a quiet setting. For our study, we wanted to imitate more real-life conditions where noise is actually present. So how can we hear any effects of LSVT LOUD in intelligibility when imitating real-life conditions, we used noise. So here we try to replicate a cocktail effect. So you have to picture someone with Parkinson's, for example, going into a restaurant before treatment, and this is the background noise. And then after treatment, going back to the same restaurant, and all things being equal, the only thing being different was that person received treatment. Can we understand that person better or not? So now you're going to hear a male speaker with Parkinson's pre and immediately post LSVT. And so what we did was we had listeners write word by word what they heard. The result was significant gains pre to post, and also after a month of LSVT treatment. I don't know if some people in the audience speak Spanish, but it doesn't really matter. I'm sure that you were able to detect one of the sentences in the sentence in the second audio clip, actually, as the speaker became more intelligible. For this study, we also used the Voice Handicap Index, which you may be familiar with. It investigates the perceptions of voice impairment on your day-to-day life, and we also found significant improvement in such perceptions. So conversation and narrative intelligibility is now being explored more in depth in English as well, and we wanted to present the first randomized control trial actually on the topic, which was done with English speakers and recently submitted by Dr. Erika Levy, which is wonderful. This is a project actually that in terms of intelligibility that we got started in 2014. So it's been a while. And as you can see, those who received LSVT LOUD became significantly more intelligible post-treatment. And the great idea would be here to expand it to more languages, keeping the rigor, the methodological rigor of RCTs. So very exciting line of research. But what about post-treatment gains in other languages? So in the following slides, we're going to present some of the main findings from different studies in different languages, and I'm going to get started with the French study from 2015. This study focused on acoustic effects of LSVT, so the impact of treatment on vowels and consonants in French. And as you can see, speakers became louder and their vowel space expanded, vowel duration became longer, and production of consonants and vowels became more distinct. In the Japanese study, we saw an increase in sound pressure level, so in vocal intensity as well, and an increase in intelligibility, which in this case was measured through a Likert scale. So it was a subjective measurement of intelligibility. And what the authors in the Japanese study found was immediate post-treatment gains in intelligibility, which, however, were not maintained after 3 months. So what contributes to it? What contributes to keeping those intelligibility gains? The authors hypothesized perhaps they needed a bigger sample size. They had 21 speakers for this study. Perhaps they needed more. They also hypothesized perhaps they needed a more homogeneous severity groups. But we also have to think that, did these patients, for example, carry over the motor routines established by LSVT? Those are things that are very interesting to keep investigating on. As for the Brazilian Portuguese study, it also focused on acoustics, and basically they determined an improvement in different prosodic variables. For example, they found greater intensity, an increase in fundamental frequency measures. And what I also found interesting about this study was that they actually implemented a modified version of LSVT in which they provided intensive therapy twice a week for 8 weeks. So as you can start comparing and contrasting the results from different languages, what we see is this emphasis on acoustics and in a different modality, kind of like twice a week. So we see also positive results. The Persian study focused on mild cases of Parkinson's disease. As the Spanish study, they also used the voice handicap index. That was their primary outcome variable, and they found improved perception of voice after treatment. In this study, which as you see is very recent, they did immediate post-test, like a day after treatment had finished. So we would need follow-up data, but again, it's the first study of its kind. And next, we have a German imaging study, which found significantly increased average fundamental frequencies and vowel space area. They also found an increase in intelligibility, which was also a subjective measure of intelligibility, and increased cortical activation. So here we already have expanded vowel space area in the French study and in the German study. In the Cantonese 2011 study, they found increased SPL and also improved intonation post-treatment. And intonation here was a perception of monotone. So there was a decrease in such perception. And as you know, monotone is one of the characteristics of hypokinetic dysarthria due to Parkinson's disease. However, there were no significant changes observed in tone. So Cantonese is a tonal language, and what they found was that lexical tone was actually relatively intact, which may actually, going back to Dr. Levy's comment on the different hypotheses, it goes hand in hand kind of with that saliency hypothesis, the hypothesis on robustness. And last but not least, the Mandarin study is actually ongoing by Dr. Su, a colleague, a lab colleague of mine. And what she found was improved intelligibility as measured by ease of understanding. We can go, Cynthia, to the next slide. Thanks. So she found improved ease of understanding, improved or increased rather vocal intensity, increased vowel space area, and increased speech rate. So again, compare this to the French and German studies. Vowel space area also increased in Mandarin. So now we have established the same results in 3 typologically different languages. Mandarin from way different than French and German. They didn't find improvement in local pitch variation, which was researched on at the syllable level. They did find global pitch variation differences, though, at the whole utterance level. And here you're going to listen to 2 different audio files. The first one is the speaker pre-treatment and immediately post-treatment. The second one is speaker pre-treatment and 6 months post-treatment.
传说中，彩虹的尾巴缠满满满的黄金。传说中，彩虹的尾巴缠满了黄金。当日光照射到空气里的一滴水。当日光照射到空气里的一滴水。
So here. Oh, so here we have something very interesting, which is they actually followed up on these patients 6 months after treatment. The Japanese study did so with a 3-month follow-up, the Spanish with a 1-month follow-up. So it's very nice to see the 6 months follow-up in the Mandarin study. And now you're going to look at German speaker pre-post LSVT loud, and then you're going to listen to a Hebrew speaker pre and post LSVT loud.
And I'll play these videos a little differently. I noticed there was some comments, some people had a trouble hearing the audio the previous way. There might be a little lag in the video, but the audio is the most important. So we'll play it this way.
Ja, wie ist sie denn jetzt im Moment?
Ja, jetzt schon ein bisschen leiser und ich würde sagen, die Muskulatur, mimische Muskulatur ist noch ein bisschen gedämpft. Mhm. Wenn man mal reingefallen ist, muss man wieder aufs Brett draufkommen. Das, für Anfänger heißt das, aufs Brett draufsteigen und an einer Schnur das Rig wieder hochzuziehen, was sehr anstrengend ist und ein Balanceakt bedeutet und bei vielen Wellen vor allen Dingen sehr schwer. Besser ist, wenn man im Wasser das Segel schon so ausrichtet und leicht anhebt, dass der Wind unter das Segel greifen kann und den Surfer mit auf das Brett zieht.
בטורונטו עשו לי בחינה של היגיון, רצו לראות אם שווה לנתח אותי. אז בדברים הגיוניים קיבלתי 10, כשהייתי צריך לחזור מספרים סתם, או דברים סתם, הצלחתי 0. אתמול פעם ראשונה ישבתי וניתחתי את המלחמה, מה שיש להגיד על המלחמה, במשך חודש לא דיברתי על המלחמה, כי היה לי קשה לדבר.
All right. So studies on LSVT LOUD have not just focused on idiopathic Parkinson's. The following Italian study compared the effects of this speech treatment in patients with Parkinson's and progressive supranuclear palsy, which is a type of Parkinson's plus syndrome. And results showed increased SPL, so increased vocal intensity and maximum phonation duration. However, improvements in vocal quality and articulation were more significant in the PD group only, which is expected. LSVT LOUD has shown efficacy for idiopathic Parkinson's disease, but it's also encouraging to treat other, perhaps more severe Parkinsonian syndromes as well. So that was a great study. And just I think it's very fun to talk about how the word loud is around the world. So it's as I said, I think it's very interesting how different languages may conceptualize the word loud, the concept of loud, which is the Q for LSVT. In Spanish, for example, you can actually see fuerte in Italian, forte. You have fort here in French, but because in Catalan, which is my second native language, we also say it like this, but the pronunciation would be fort. So I'll just say it in Catalan. In Spanish, we have two translation equivalents for the word loud, which would be alto and fuerte, and both are technically valid. If in the audience there's someone whose native language is Spanish, I would be very interested to hear about your perceptions on translation equivalents for this word. So from my personal experience, when I started working with these patients, I chose the word alto to get me started. But then I soon realized this word actually made patients think they had to yell, and they would report feeling uneasy with neighbors, thinking neighbors would start knocking on their doors or calling the police. So soon afterwards, I just found a better translation for fuerte, which would actually relate to the concept of power. And I found that this correlation between the target Spanish word fuerte and power worked really, really well. And I think Erika also has different words for all her different languages.
So there's hlasity for Czech, and I had a similar experience to Dr. Moyle-Gale with the word fort in French, in that it really brings out a nice voice quality that is a combination of strong. Fort also means strong, so strength and loudness, and that combination I think brings out a nice vocal quality. With an Austrian speaker who with Parkinson's disease, he did not feel comfortable speaking laut, which is the word used in German. And I think there could be a cultural aspect of that as well. But then after I explained that really we're looking for a good quality, healthy, loud voice, eventually he understood that it was a cue and that it brought about a good vocal quality.
So just as a wrap up of this cross-linguistic section, would also be interesting area of study to examine how different cultures perceive loudness, because definitely what we know is that in order to make any treatment successful, of course, we would need to know what is appropriate in each culture.
Okay, thank you both so much interesting information and areas for future research. And I'm just going to do a little wrap up and then we'll open for questions. And, you know, I love the discussion of the term to use for loud in different languages. And we have found as a training organization, every new language we go to, it may take a little work with clinicians, trying with patients to find the right term that captures what we need. But for all languages and all cultures, no matter what, we have to retrain the self-perception of normal loudness, because for every person with Parkinson's disease around the world, it feels unnatural. And as you see on the left, the person feels like they're shouting. And what we have to be successful at is at the end of the 16 sessions, they're confident with the voice. They recognize it's normal, it's not too loud, and that it has this very positive effect in their daily communication. So one last comment here is the idea that, yes, the treatment may be universal, but from the clinician perspective, is the treatment approach possible to be universal? And by that, I mean, will clinicians engage in the protocol and find their ability to deliver it to patients? So we were interested in this and we decided to look at impressions from clinicians, LSVT certified clinicians in Germany, France, and Japan. And since 2000, we've carried out 35 training and certification courses across these countries, resulting in more than 3,000 LSVT LOUD certified clinicians. We've had 404 who responded to this survey from Germany, France, and Japan. This was a reference for one of the presentations of these data at the ASHA convention in 2019. And in general, what we found, if you look at the graph in the upper left-hand corner, that most clinicians felt they received effective training, and all of the training materials and, of course, the languages were translated either through simultaneous or consecutive translation. In terms of confidence, we found greater confidence in German and French versus the Japanese therapist. But in terms of outcomes, do you feel you had better outcomes with LSVT LOUD than previous treatments? We had very positive perceptions that LSVT LOUD resulted in better outcomes. And then a clinician's perspective of were patients satisfied or not. In general, very positive. But these are important data for us as an organization to investigate, because clearly there were differences in confidence of delivery and perception of patient satisfaction across countries. And that may be attributed to cultural differences in reporting, how we ask the questions to therapists, but it also tells us something about maybe things we need to do better or add as a training organization, so that not only are we keeping the fidelity of the treatment intact, but the fidelity of the training for clinicians around the world. So in summary, there are perceptual and acoustic features of Parkinson's speech that appear to be universal. As Dr. Levy, Dr. Moyle-Gale have talked about, soft, monotone voice, imprecise articulations, but there may very well be language-specific deficits that exist, are understudied, and certainly do need to be explored. LSVT LOUD is a well-established evidence-based treatment that improves communications, and we now see in speakers with Parkinson's disease across multiple languages, and that's exciting. And likely that focus on the sensory motor disorder that is the same in patients around the world, because it's really the physiological underpinnings, can be the key for the multilinguistic improvements we see. But more research needs to be done on language differences to see if we can make it more successful. And from the clinician perspective, we have had successful clinical implementation, but need to continue again to explore these language and cultural differences to maximize treatment outcomes. For your reference are the references that we cited. These are opportunities to be able to learn more, but where I'd like to go now is to our question and answer session. We are at the top of the hour, so if you do need to log off, you have completed your 1 hour requirement to earn that self-reported CEU. However, if you do have questions, please type them into the control panel, or you can click the hand, we'll raise your hand and your name will be called out, we'll unmute your microphone and you can ask your question. So as those questions begin to come in, I'll pose one to Dr. Levy, Dr. Moyle-Gale, and it's this idea of audibility and audibility's role in intelligibility in any language. And it comes from two perspectives. One is many intelligibility studies are not done as you did, and the volume is normalized. So we take audibility out of the question. The other thing that always surprises me is when I work with patients, whether they're English speaking or not, who are very soft, we get them louder, and suddenly I can hear the accent, the dialect that was completely lost with inaudibility. So how do you think the role of audibility is so important in intelligibility?
I would love to say a little something about that because that's one of my passions. And that also speaks to the universality. So as one of the characteristics of Parkinson's disease, hypokinetic dysarthria is often very quiet speech. So if you are quiet, you will not be understood. Right now, I can whisper something. I just did. Did anybody understand me? No, because you didn't hear me. So universally, that is something that's a problem in Parkinson's disease. And universally, if you make somebody speak louder, they will become more intelligible because they are more audible. And as Cynthia pointed out, a lot of studies don't really take this into consideration, and they have the listener be able to turn up the volume when they're listening to a sample. Well, in life, we don't get to turn up the volume when we hear someone. So it's not a good representation of the person's speech. So in our studies, and this is all very influenced by Dr. Lori Rami, Dr. Moyle-Gale, and I always make sure that we stick to the volume that's actually being uttered. And so I think that's important. And then along with loudness, something else that seems to happen universally is it's not just the audibility, and the audibility is very important, but all the things that come along with speaking louder. And that means a change in fundamental frequency, the mouth opens wider, and many other things. And that seems to be universal as well. Dr. Moyle-Gale, did you have anything?
No, just stemming from what you're saying, basically it's like you said, like not adjusting those loudness level when we do all these experiments to reflect real life conditions. And it's really, it speaks volumes about the role of noise, right? It's just whenever we are, typically there's some kind of noise background. So just making the speech signal audible seems indeed to have this universal property of increasing intelligibility, as the different studies we've been doing have shown, in which we really keep that noise as realistic as possible and maintaining those levels, as you said.
Great, thank you. A question came in about the usual word for loud in Japanese has negative connotations, meaning too loud. And the question from Carla is, did we have that conversation when planning the Japanese edition? And yes, I think that we certainly had questions. And as we zoom in on the word that we use for consistency, we find one that we can keep consistent across our trainings. However, therapists, again, working with a patient may make subtle modifications. And I've certainly used the word, and I think Dr. Moyle-Gale mentioned this, as did Dr. Levy, power, something about power in your voice. And if it drives amplitude, that's really what our goal is after. So there may be words that work better for a particular patient who has a resistance to a certain word. I know that, for example, in the pediatric population, you're not supposed to talk loud in school. And that was one where we really switched to a strong voice, power voice, so that it had an acceptable way to carry it out, but yet you're driving that same target and same physiological response. One last question, I think, for the two of you. What about African languages? And I know when we did some initial work in South Africa, I was astounded by how many languages and how many are based upon things like clicks and certain vocal sounds. Have you done any work or any experience in African languages?
Well, I have not done any work myself, but I'm definitely interested in learning more about how, for example, this kind of treatment would work with a language that is characterized by clicks. Absolutely. I think it's such a fascinating area of research.
I would agree with that, and definitely an area worth exploring and that hasn't been explored much.
Mm-hmm.
Great. Well, I can't thank you enough, Dr. Levy, Dr. Moyle-Gale, for sharing your passion and your perspective. This clearly is a very interesting question. If any of you listening have additional questions that come up afterwards, please feel free to email us and we will get back to you. Thank you very much, Dr. Levy, Dr. Moyle-Gale. Thank you everyone for attending, and this will also be available as a webinar on demand. So if you have colleagues who you think might be interested, in about 24 to 48 hours, it will be posted on our website. So we thank you, and we wish everybody safety and health in these uncertain times. So thank you.
Thank you.
Thank you so much.